Bismillahirrahmanirrahim. Hello everyone. Today's topic is about point-of-care ultrasound and pulmonary embolism and how POCUS can help in diagnosing and managing patient with suspected or confirmed diagnosis of PE. So let's start. These are just some of the resources that I used. Some of them are case reports. Some of them are some studies, prospective studies. Some of them are systematic reviews and meta-analyses that tackle the topic of point-of-care ultrasound and bedside ultrasound in PE, in case you want to get more insight about the topic. So as you probably know, CT pulmonary angiography or CTPA is the most sensitive and specific test for diagnosing PE. So it's considered to be the kind of the gold standard in most of the studies that they look for testing and pulmonary embolism. So if you compare point-of-care ultrasound or POCUS, the sensitivity is between 45 and 60%, and specificity is between 74% and 90%. So for me, this specificity is actually really good. I think it tells me, yes, when I'm not gonna maybe find all these findings in patient with PE, but once I see some of these findings, it really makes the diagnosis more likely, and then I can move further. This in addition to the other benefit of POCUS, as we already know about it being safe without harm compared to the angiography, CT scan, side effect and radiation and contrast-induced nephropathy and all that. So looking at the evidence, looking at some of the studies that examined the different ultrasound modes and exams for PE, it's actually also says a lot about how POCUS can be really useful. So in this prospective study done in or published in 2014, basically looking into what's called the triple POCUS, lung POCUS, heart ultrasound and leg vein ultrasound in 357 patients who had either a Wells score more than 4 or a positive V-dimer. They found actually the triple POCUS exam has a sensitivity of 90% and a specificity of 86%. And a meta-analysis published in 2020 also looked into the thoracic ultrasound and cardiac ultrasound for diagnosing PE. Also did find similar results with a sensitivity about 90% and specificity about 80%. And this is a very recent, also systematic review and meta-analysis just published actually just last month. And it looked into also again the DVT, lung ultrasound and cardiac ultrasound. For lung ultrasound, for example, finding one or more hypoechoic subpleural lesion. We're going to talk about all that when we talk about the lung ultrasound for PE. They found that this finding has a sensitivity of 80% and a specificity about 87%. The D sign in cardiac ultrasound, again, we'll talk about that, has a sensitivity about 30%, but specificity more than 95%. And seeing a right ventricular thrombus has a sensitivity of 5%. It's really low, as you can expect. You're not going to see that all the time, but it's very specific, almost 100% in this study. And then the McConnell sign, we'll talk about that as well. It has sensitivity of about 30% and more than 98% specificity. So again, you see the pattern here that most of these individual studies, yes, the sensitivity might not be the highest, but when you combine them, it's actually very high, and even individually the specificity are really good. So that's kind of a pattern that is seen with POCUS for PE in general. Looking at the studies that only examined the lung ultrasound for PE also had kind of a similar results. And I mentioned these studies specifically because, as you can tell, with cardiac ultrasound, you can do an echo, and then you get the report. But with lung ultrasound, most of the time it's not really rarely ordered. So it's really good that at the bedside, a hospitalist, acute medicine physician, or general internist, and even in the outpatient setting, if they have the portable ultrasound, they can do the lung ultrasound really quick. So, for example, in this study in 2005, looking into 194 patient diagnosed with PE, they used the criteria of the 2 or more typical triangular or rounded pleural-based lesions. Again, we'll talk about that. And they found that compared to the CTPA, the sensitivity is 43%, but the specificity is really high, close to 99%. This study in 2013 also looked into it's a systematic review, and they found sensitivity to be around 87%, or specificity more than 90% for lung ultrasound in PE. And another meta-analysis, more recent in 2015, also compared to CTPA, the lung ultrasound for PE has a sensitivity of 85% and a specificity of 83%. So this is just the lung ultrasound, not taking into consideration the DVT or the cardiac ultrasound. And this number, I think, is really relatively good. And the lung ultrasound, with some experience and practice, I think it's a skill that can be gained hopefully quick by internist, acute medicine physician, or hospitalist, or even general internal medicine in the outpatient setting. So we just talked about the triple POCUS. So basically what that is it's a combination of doing 3 ultrasound exams. The first one is the cardiac POCUS, or cardiac ultrasound, or basically the echo. And the goal of that test is to detect right ventricular strain, which indicates like right ventricular overload and or right ventricular dysfunction. And this finding can suggest that the patient is having a larger burden of pulmonary emboli, probably bilateral. So even in sicker patient, when if the patient is hemodynamically unstable, then this test is really useful. It's actually probably the most appropriate initial test to do in these situations, because if the patient is having hemodynamic instability and you do a cardiac ultrasound and you find that there is clear signs of right ventricular strain, especially if a previous echo or ultrasound was normal, then this is actually an indication to start TPA for these patients, and this can really improve the outcome and improve the prognosis, and technically can save lives in many situations. So, and also another useful side of the cardiac POCUS in these situations is that it can detect other cause of hemodynamic instability. For example, it can easily detect pericardial effusion and presence or absence of tamponade in these patients. So this is the first exam, the cardiac ultrasound or cardiac POCUS. The second one is the lung ultrasound. And we usually look at the subpleural consolidations that you mentioned before. We're going to show you some videos and images, and then most of these are accompanied by B-lines as well. And some, not all, of the pulmonary embolism, especially if associated with infarction, they might have some new small pleural effusions. And also you can look at the leg for DVT. You can examine the femoral area and the popliteal area, and using the compressibility. So we're going to talk about these two, and then I'm going to have like a separate video about POCUS to look for DVT with or without pulmonary embolism.